There we go. Sorry for the interruption. So it's important in terms of understanding eating disorders to have kind of a framework for how to understand them. So in Western New York and at Healing Connection, we understand eating disorders as diseases of disconnection. And what I mean by that is that the goal of an eating disorder is to disconnect the student from themselves, from their own genuine thoughts, feelings, needs, from being able to tell what's going on internally, even understanding what's emotional hunger versus physical hunger, what's emotional fullness versus physical fullness. All of that, which involves information processing, becomes a big problem for kids who go on to have eating disorders. So their feelings, their thoughts, even their internal sensations are very confusing to them or overwhelming to them. And so that's the goal of an eating disorder, is to disconnect the person from their own internal states, psychological and bodily. And its goal is to disconnect the student from people who love that student, who want to care for that student. Once a student or a patient has an eating disorder, they are either so dehydrated, so distracted, so starved that not only do they not know what's going on inside of them, they're not able to tell adults who care and love them what is going on, right? So now your family also doesn't understand what's going on. And so now there's a disconnect there. And then when family members do kind of get a hint that something might be going on, they're not quite sure what to say or do about it, more tension, right? More disconnection. And then it likes to also disconnect family from extended family or friends. When you have a kid who has an eating disorder, it's hard to go do normal things socially because people don't understand what's going on with your child. So people tend to avoid social engagements, which further disconnects the family and stops all that great positive energy that comes in from people who love you. Like there's like entropy going on now, right? And so you need more energy, not less energy when your kid is sick. And then what happens is whatever disconnection that the student's feeling inside and whatever the family's feeling with the student starts getting replicated with regard to relationships with healthcare team, right? So the eating disorder doesn't want anyone to talk to anybody, and it likes to disconnect, divide and conquer. And it does this in a number of ways. For example, the way a student thinks is very all or nothing, black and white. And so whenever you see an eating disorder on the scene, one of your first tips is people are thinking in very all or nothing ways. It gets all of us thinking in that way, not just the student, because we're frightened, we're anxious, we're overwhelmed, we're distracted, we're fatigued. There's a huge burden of illness. And so then family, school personnel, mental health people, all of us start thinking in all or nothing extreme ways because we've just feel like overwhelmed and we're not sure how to respond. And then if the treatment teams are really honest with you, it's not just a student, it's not just a family, it's not just a family with the professional team members, it's within the team itself that people start pointing fingers at each other. There's lots of splitting that can happen, which means that, you know, some people are the good nurse or the good school counselor, then there's the bad nurse and the bad school. That kind of thinking is the eating disorder at work, because it doesn't want us communicating with each other. So is everybody with me? That's how we think about this illness. And so you guys are so essential because you can put a stop to that. You can foster connection, and that's what we're banking on. And you can help with identification. So when there's lots of disconnections, I want to give you examples of a few. What happens is, whether we're school personnel or whether we're treaters outside of school or whether we're parents, we can get so burdened by the illness that we can become these animals on the bottom here. So avoidance, when we get tired, distracted, we get fearful or anxious, or we just want to think that there's really nothing wrong, it's just a phase, we're acting like an ostrich. I'm a mother of a kid, right? I like to think that with my son, if anything seems like it's going awry, it's just a phase, right? That's a normal way to think about it. We are all very hopeful. We want things to kind of pass. But you know what? Eating disorders don't pass. They're not just a phase. So we can get kind of ostrichy and avoidant. Or we can get overprotective. We want to take the student, put them in our pouch, and not let them hop out, right? Or we keep our children very close to us. We're afraid to let them try new things. We're afraid they're going to get hurt. They're going to get in trouble. And we keep them too close sometimes. And we don't let them, get their sea legs and, face some challenges that they need to face to get their sea legs. Or we can get very aggressive. We get tired, overwhelmed, pissed off, tension-filled, right? We all have very busy jobs, and what happens is the eating disorder is bearing down on us and on the family and on the student, and we just are like, why aren't they doing what we're saying? Or, we kind of charge at the student or charge at the family. We don't mean to, but we're all feeling overwhelmed. We don't want to do that. Or we can be like terriers. We can get very critical. What do terriers do? They yip at your heels, right? And we can kind of get like that. As a parent, we do that anyway sometimes, right? Because we mean well, but we can get kind of critical and snippy. And then the last one, which you can't see, is a jellyfish. And when we get really overwhelmed and emotionally dysregulated, we can be like a jellyfish. So the student's upset, we're upset, the student's crying, we're feeling like we're going to cry, the parent's upset. And so this kind of inability to center is what the eating disorder wants, right? It's going to create more disconnection, more dysregulation. So these are all the animals that we can become if the eating disorder has its way and it's creating tension and disconnection. The animals we want to shoot for are the animals at the top, which are the dolphins and the St. Bernards, okay? What do you notice about dolphins? What do you notice on there? What do dolphins do? Yes, they swim together. They swim alongside. They don't go too far up. They don't stay too far back. And guess what happens when a dolphin gets off track? Do they charge at each other like rhinoceroses? No, they just gently nudge each other back on track. And that's kind of what we want to cultivate. That's the frame of mind. That's the response we want to have with parents, with each other, with students when they kind of get off track. And then look at that St. Bernard. It just screams of compassion and centered and available. So that's what we're shooting for in terms of how we want all of us to respond in the face of an eating disorder, which doesn't want us to respond that way. So now what I'm going to do is talk a little bit more about disordered eating disorder, so I can get back into why Project ECHO might be helpful. So some of you may know this, some of you may not. So when we look at teens, middle school and high school, this is from the work of Diane Newmark-Steiner, who wrote a book, which is excellent. It's called I'm Like So Fat. If you had to buy one book, an amazing book. So she's done lots of longitudinal research with kids and diverse samples of urban kids, lots of ethnicities, lots of races. And what she found is that when you looked at those kids, that almost 60% of the girls have unhealthy weight control behaviors. And I gave you examples: skipping meals, eating very little, fasting or smoking for weight loss. And then look, over a third of the boys are doing the same thing. People didn't think boys did that. Well, they do. And probably more boys now than ever are engaging in those behaviors. In terms of dieting, over 50% of the girls and over a quarter of the boys. And then look at body dissatisfaction. Almost half the girls and over a quarter of the boys are unhappy with their bodies. And then when you look at extreme weight control behaviors, which includes things like vomiting and laxatives and diet pills, 12% of girls, 5% of boys. And then I've also put in statistics on binge eating. A little under 20% of the girls, 8% of the boys. Obesity, 15% of girls and boys. And then moderately overweight or at risk for obesity, 15 to 20%. So these are like big numbers. And so our kids, not all these kids are going to go on to an eating disorder, but it makes me very unhappy to look at these statistics. And I'm sure you feel the same way. Not surprising, and we'll get to why in a minute. Then if you look at frank eating disorders in adolescents, those prevalence rates seem like they're low, right? So, but it's not, I don't want you to get stuck on low prevalence rates. Like eating disorders happen 1 in 50, right? Or for anorexia specifically 1 in 200, for example. But it's not the prevalence that's the issue as much as the magnitude of things that happen when the kid does get an eating disorder. Because your mortality risk, your morbidity, having other illnesses, all that goes through the roof when you have an eating disorder, especially if it's not quickly identified and it becomes more chronic. The median age for kids in adolescence is 12 to 13 to get an eating disorder. If you're vulnerable and you don't get it going into high school, the other window is going into college. That doesn't mean that people in midlife, and that might be some of us in the room, that's me. That's another time people can be at greater risk because there's lots of transitions, lots of hormonal changes, bodily changes, psychological changes. So I also wanted to mention, and you'll hear this in other slides, that when you are talking eating disorders, you're talking about increasing impairment functionally and suicidality, all right? So even though it might not be the same as depression, which happens 1 in 4 or 1 in 5, it's still the magnitude of what happens is very serious. There's an increased prevalence in males, so I want to put to bed this myth that guys don't have eating disorders. They do. And if you looked at not clinic samples, because remember, guys are never supposed to go to health in our culture. If you don't look at clinic samples, you look at community samples, you're going to see way more boys than you expected. If you looked at pre-adolescent boys, like under 13 or 14, the ratio is like 1 boy for every 6 girls. It's not just 1 to 10 or 2 to 10 that you see in a clinic sample. It's way worse. And eating disorders have no specific face. They cut across races, ethnicities, sexual orientations, genders. And minority girls and some boys engage in unhealthy weight control practices like food restriction for at least 24 hours or more. And they also engage in vomiting and laxative use. And you'll see, sadly, that the Hispanic girls actually outperform the white girls now. And you see in the studies. Latina girls are not getting the care. African American girls are not getting the care. Asian girls are not getting the care that they need because people don't think of eating disorders. They have this kind of mythical idea that only rich white girls get eating disorders. So forget that. That's not true, all right? All right, so stick with me on this slide. There's a lot. This slide is full of different factors that predict over a 5-year period whether kids go on to 1 of 3, 2 of 3, or all 3 outcomes, including overweight, binge eating, and extreme weight control behavior. So on the left, you're going to see socio-environmental factors that predict at least 2. Either they're going to become gaining weight and get overweight, or they're going to have binge eating, and or they're going to engage in extreme weight control behaviors. So things like parental weight concerns, things like weight teasing by your family, looking at magazines that focus on weight loss, and what's going on in the home environment, like your meal frequency, which is protective, not a risk factor, but protective, and family meal atmosphere, again, which is protective, right? In the middle are personal, individual factors that predict risk. So like body dissatisfaction for girls and weight concern for boys and girls can predict those outcomes I just said. And then in the last column, which you can't see, weight control practices, including dieting for girls, unhealthy weight control practices for boys, and then protective is lunch frequency. So tell the lunch monitors, right? If you're having lunch frequency, it's higher, you're more protected. So what I want you to really pay attention to, though, are the ones with the 3 orange asterisks next to them. Weight teasing by family for girls, weight concern for boys and girls, which is part of body dissatisfaction, and dieting and unhealthy weight control behaviors for girls and boys. Those factors are the ones that predicted all 3 over a course of a 5-year period. So at the end of 5 years, those kids who did those, engaged in those behaviors or had those experiences, it predicted overweight, binge eating, and extreme weight control. So basically what I'm saying to you is the more weight concerned and the more focused we are on body, on negative body, image, the more we create risk in kids who could go on to developing an eating disorder. Now, it isn't that simple, but like if you're anxious, if you're perfectionistic, if there's a family history of eating disorders, everything starts mounting up, right? And then if you add weight concern to that already fueling fire and body dissatisfaction and unhealth and weight control practices, it starts really adding up. So in schools, I'm talking to you because this is where a lot of action occurs around how kids talk about themselves in terms of their bodies. They hear how faculty talk to each other about their bodies. So this is like a breeding ground, and no one is immune. We're all having to work on this together because our culture does not help us with any of these things. In fact, our culture is toxic. So if you have asthma and you live near a polluting factory, guess who's going to have problems first? So if we're in a culture that's already toxic and you're anxious and perfectionistic, and you start worrying about your weight, which we make ourselves worry about it all the time in our culture, this is it's a recipe for disaster. So I wanted to share with you the things we have to watch out for. The other reason why training about eating disorders is important for school personnel is that when you look at the numbers, a majority of kids with eating disorders do have contact with service providers like mental health care folks, school services, or general medical services, but only a minority have ever specifically talked with a professional about their eating disorder. I have kids and adults who tell me about their sexual trauma before they tell me about their eating disorder. They tell me about their addiction before they tell me about their eating disorder. It's one of the last things that a kid is going to actually tell you about, which is why it's important to know the signs and know kind of what to worry. Also, as I said, mortality and morbidity for eating disorders, very high. It has the highest mortality rate of any mental illness. And the risk of dying goes up 5.6% every decade you have the illness. And if you follow people out 20 and 30 years, the risk of dying is 20%, 1 in 5. Now, probably some of that has to do with the fact that it's a new science and we still don't have the treatments that I feel are effective enough. Hopefully that mortality rate will come down over time, but there is 5% of folks who will die with an eating disorder right now. For women with anorexia ages 15 to 24, the death rate is 12 times higher than the death rate of all causes for people in that age range for girls. And 20% of deaths for those with anorexia is due to suicide, right? That's almost a quarter. And every hour a person dies as a direct result of an eating disorder. A lot of people don't realize this. Let me just go back for a second. So when you think about co-occurring illness or comorbidity, lots of times with eating disorders, for example, with anorexia, a third to half of persons who will have a mood disorder, for example, depression. And when you have anorexia, about half of individuals have an anxiety disorder. That anxiety disorder often is a precursor to an eating disorder like anorexia. It doesn't always have to be a precursor. You can also acquire it because the illness bears down on people and really wears them down and makes them more anxious if they weren't already anxious. And of course, with bulimia and binge eating disorder, you may also have depression and anxiety. In terms of substance use, it exists in at least 10% of those with bulimia, binge eating disorder, or what's called OSFED, other specified feeding and eating disorders, which is the category we put human beings when they don't fit neatly into bulimia nervosa or anorexia nervosa or binge eating disorder. So substance abuse definitely is potentially going to be a co-occurring illness. And also people used to have this idea that if you had restrictive anorexia nervosa, that you wouldn't develop alcohol problems. Well, you can. And the longer you have anorexia, for example, by the time you're in your 30s, if you're still actively ill, the chances of having an alcohol use disorder goes way up. So it's also important to think about kids with diabetes mellitus type 1. So about 40% of females and 50% of males with diabetes will have disordered eating behaviors that will put them at risk for all kinds of medical complications that are going to hurt their kidneys, hurt their nerves, create diabetic ketoacidosis, which means your body starts breaking down fat because you're not taking your insulin to help process your sugar, your glucose, and the fat starts breaking down, and you get ketones, and then you get acid, more acid in your blood, and it spills over into your urine, and you can die. For post-bariatric surgery folks, people with binge eating or loss of control eating can have these kinds of eating disorders when they're post-bariatric surgery. So like a quarter of patients who are post-bariatric. Also, 25 to 30% of people in weight loss management university-based clinics have an eating disorder. Whether anybody knows or not is a separate issue, but it's more than you think. In terms of financial burden related to eating disorders, if you look at age-adjusted costs for the treatment of anorexia and bulimia, they were examined in a study, and what they found is that it costs equally as much to treat anorexia and bulimia as it does to treat schizophrenia. Very high treatment costs. So that's why we think school personnel could be a huge help in quickly identifying folks before they go on to more chronic illness, right? From 1999 to 2000 versus 2008 to 2009, hospitalizations for eating disorders went way up, 72% for kids under 12, 6% for ages 12 to 19, and overall age groups, almost 25%. From 1999 to 2000 versus 2000 to 2008 to 2009, total hospital costs for eating disorders went up 68%. That's a lot of money spent on eating disorders. In terms of caregiving burden, I mentioned a little bit of this. Most folks with an eating disorder, sadly, will go untreated, maybe up to 90%. And among those who do get treatment, they probably aren't getting the level of treatment, the intensity of treatment, I have some nods, that they really require, because people don't understand how to think about levels of care. And then the caregiving burden for anorexia has been well researched, and it equals the caregiving burden that family members feel when taking care of someone with schizophrenia. It's exhausting, it's stressful, it's distressing for the patient and for the family members. And the eating disorder loves this, right? It loves to produce more stress, more tension, more disconnection, more tension. So if these things are all true, and they are, then what are the challenges for us and for school personnel in terms of identifying quickly and intervening quickly and collaborating together to help integrate things for kids and families? Well, some of the challenges already exist in our culture, right? So our culture, we could do whatever we want with a kid in school or at home. They walk outside, and then they're exposed to lots of toxic cultural values, things like you're supposed to take control and be thin, how thinness is linked with success and beauty and control. And unfortunately, our culture makes adults think that way, and adults, without realizing it, pass on this attitude towards children. In our culture, we stigmatize obesity, and we conflate weight with health. So I want to remind people, just because you're a certain weight does not guarantee you health. In fact, the people who are in the most trouble, it's a U-shaped curve. People who are really super thin and people who are morbidly obese are the people in trouble. The people who aren't in trouble for health problems are in the middle. So if you're 10 to 20% beyond your average, you're actually in a better place than being average. So that's how you want to think about it. But that's not how our culture thinks about it. It makes us feel very bad if we don't fit into a small window called 0 to 2. Most people who are 0 to 2 get there because of an eating disorder. If you're just biologically 0 to 2, great for you. But you're 1 to 2% of the population, maybe. All right? So our kids end up internalizing the thinness ideal. And people who internalize the thinness and have other biopsychosocial risk factors can go on to develop an eating disorder. So things like weight bias and internalized thinness, those things increase kids' body dissatisfaction and weight concern. And what did we talk about? We said when there's more body dissatisfaction and more weight concern, there's more risk for eating disorders and disordered eating and body image disturbances. Also, the other challenge is that evidence-based prevention models are not systematically used in schools or in treatment sometimes. So that's not a good thing. We need to get those models out so people understand what they are. And our culture also has separate silos for obesity and eating disorders and pretends as if there's no connection. Now, of course, obesity is a medical problem, physical health problem, not a mental health problem, all right? Eating disorders are mental health problems, but both a health problem that's obesity can also involve depression, anxiety, binge eating disorder as well. And someone who has an eating disorder can go on to have anxiety, and other physical health problems. So they can be seen as difficulties with weight for different reasons. Okay. So, and also people can start out with one and develop the other, or have both simultaneously, or we can try to treat one of those conditions and unknowingly create problems with the other, right? Because people think, focus on weight loss. Well, that's not a good thing to focus on. We want to focus on habits, not numbers on a scale. So as we already said, the best predictor of eating disorders and disordered eating and body image problems is body dissatisfaction, and especially weight concern across boys and girls. Be on the lookout for that. We talked about weight stigma and bias, how that actually backfires and creates more risk for our children and for us, and how dieting has actually been found to increase weight gain, not decrease it, all right? Boys who go on to diet when they're not supposed to be dieting, like in puberty and early adolescence, have a 12 times higher risk of binge eating than boys who don't, and girls have a 7 times higher risk of binge eating than girls that don't. Obesity and eating disorders have been considered distinct, and I kind of just put that to bed. We also have separate silos for primary care and behavioral health. This is very bad. We don't even integrate the body in our healthcare system, right? And primary care and behavioral health don't talk to each other the way they should, let alone talking to the schools, right? Which is crazy. We should all be talking to the schools. Like mental health, behavioral, primary care, and schools should be like a triangle. And so when the communication does not flow, you can't have integrated collaborative care when that's not happening. The eating disorder loves that, right? More disconnection. Now the providers aren't talking to each other. So the other challenge is that to really treat an eating disorder properly, you need to be part of a true multidisciplinary team. And the basic parts of a true multidisciplinary team is having a primary care provider, and in your case, a pediatrician or an adolescent medicine physician or NP, a registered dietitian, some kind of mental health provider is a therapist, sometimes a psychiatrist, and school personnel. This is the professional part of the team. The other parts are the family and the patient. And in Western New York, we're lucky. We have a parent peer mentor. We have a young adult peer mentor. So we have a care coordinator. We have all those people coming together to talk about a case. And so when you talk about eating disorders, you really have to get savvy in terms of understanding the physical health issues and the behavioral health issues. That can sometimes feel overwhelming. And there's also a shortage of specialty trained medical and behavioral health providers, not only in school, but out of school. Try to get help for a teenager who needs to see a psychiatrist. Okay, that's already hard enough. Then try to get someone to see an eating disorder specialist. All right, and before the Healing Connection existed, that was very hard. The wait lists are through the roof. So the Healing Connection has an outpatient clinic now, so that makes it a little bit more accessible. You also need to work very closely with parents. All right, not that you wouldn't do that for any other illness, but they need support. And I've talked to folks in schools. A lot of people aren't trained in eating disorders. They feel very awkward. They're not sure what to say to parents when they see something going on. We can solve that, don't worry. But it doesn't feel comfortable. And so people kind of stumble over the words, or they don't say anything at all. Or parents and school personnel, again, we get back to the ostrich, they're hoping that it's just a phase. They kind of look the other way and think, well, this will get better. If it's an eating disorder, it's not going to get better on its own. And then if you're trying to reason with the student, you can let that, give that up. Because information processing is not a good thing when you have an eating disorder, whether it's feelings, thoughts, bodily sensations. It'll be very confusing, or it'll be very frightening or overwhelming, or they're just shut down. When you're starved, you're not yourself anyway. If you're binging and purging, your electrolytes aren't going to be what they normally are. So it's hard to even kind of reason with the student. And eating disorders are illnesses. The hallmark of an eating disorder is you don't know you have a problem, right? Especially anorexia. With bulimia and binge eating disorder, you kind of know you have a problem, but the shame and secrecy around eating disorders keeps you from going to someone, right? So the adults really have to kind of be right there in the forefront. So the other challenges we talked about were comorbidity, mortality. We talked about risk of suicide and premature death, of course, right? Because of all the comorbidity. I didn't talk about fears of litigation, but there's fears of litigation, but I want to just put that to sleep. I tell this to people in the hospital all the time. They're always worried about committing people against their will or doing something against the will of a child or student. You should worry less about that. Worry more about if the kid goes home and offs themselves, or the kid goes home and starves and binges and purges and dies because they didn't wake up in the morning because they ran out of potassium. I always tell people in the hospital, you're worrying about the wrong thing. No judge is going to hear a court case of professionals who were trying desperately to get somebody fed, to get somebody hydrated. I mean, so I know I sound like I'm being cavalier, but I've been doing this for 35 years. I've never been in a situation, I've been in court, but I've never been in a situation where a judge would ever find fault with that. They'd find fault with people turning a blind eye, and then things just go south, and then a kid dies. That's what you don't want. Dr. Starr just joined us.
Hello, everyone. Sorry for charging.
You're fine. We're just happy to have you. So without time, and you chime in, Taylor. So without timely intervention, eating disorders can become chronic. They can definitely become disabling. We don't want that to happen. We want to stop them in school so they don't follow kids out into young adulthood or adulthood, and you can die. So we're hoping that we can figure out a way to teach timely evaluation and referral and identification so that kids and adults don't end up in the emergency department or on costly inpatient or residential units. And when you look at the cost of what an inpatient or residential stay is, which is $1,500 to $2,000 a day, we'd like to avoid that. We'd like to keep people in outpatient care, because you also don't want to send kids away from their families and their schools and their peers to go get treatment. Right? We want to keep it in town, because transitions are not favorite things for these patients, right? It's hard. So even if you go to a great residential program, you've got to come back into town. It's another transition to weather through, and these guys are anxious. They might be depressed. Even when they're coming back better, it's very frightening for them. They're easily overwhelmed with transitions, even ones that are good and positive. Eating disorders, as I said, are diseases of disconnection. And so they want to make parents and school personnel and therapists and primary care folks feel de-skilled. We forget what we know. You guys are very talented. You know a lot. But when you're in the face of an eating disorder, it's like we forget all the things that we do know in terms of how we treat kids or how we work with families. It's banking on that. There's a high burden of personal and professional caregiving. We talked about that. The illness loves us to feel isolated and disconnected from each other. And we talked about splitting. So change is very difficult when you have an eating disorder. It's terrifying. It's very hard on the student. It's very hard on the families. They're not sure what to do either. And sometimes, you know, letting go of an eating disorder seems unthinkable to a kid. Because think about it. When you're a teenager, you don't really have a sense of self. In fact, you're supposed to be building one. It's very frightening to get sick with an eating disorder, and then it feels like it's a part of who you are. It's not just what you do anymore, the longer you have it. So when you say to a kid, I want you to stop that, you're basically asking them to stop being a part of who they are. And to me as an adult, it's kind of terrifying to think I'm going to wake up tomorrow and not be part of who I am, right? And kids don't have the opportunity to say, well, you know, when I was 30, things were better. They can't look back like that. So it feels unthinkable to them to stop it. And the thing it's whispering in their ear all the time about how if they don't do binging, purging, restriction, exercise, that they're bad, that they're ugly, that no one's going to like them. It's always telling them that if it doesn't do what it says, they're going to be all alone, which they're all alone anyway. But it makes them think that way in a distorted way. So in order to help kids, we have to understand things like stages of change, motivational interviewing principles, relationship building, which all of you do every day and shouldn't forget, and focusing on mutuality, which is a big healing factor with regard to eating disorders. So this is just a reminder that change is very frightening. It's very hard, not just for kids, for adults. And so a lot of eating disorder training has to do with motivational interviewing and how to talk so kids listen, right? And then how to listen so kids will talk to you. I'm going to have Jim come up and talk a little bit about Project ECHO now, because we think that Project ECHO may be a good solution to all these challenges that I just laid out for us. And Taylor, I'm going to invite you to feel free to jump in too, because I don't want to put the bird. Yeah, you're good at that. So Jim's going to tell you a little bit about Project ECHO.
All right. So Project ECHO is a project that started at the University of New Mexico in 2003. And the setting was that there was essentially one liver disease specialist in the entire state, which is an enormous, disparately populated state. And people needed treatment, and they were driving hours and hours every week to come see this physician for injections. And he couldn't keep up with the need, and people were not getting the service they needed. Poor people weren't able to get to him at all. And so he really was trying to find a way to solve that problem. And what he came up with was what became Project ECHO. And the name again is Extension for Community Healthcare Outcomes. So the idea was to extend the reach of his clinic. And what he decided to do was to hold weekly Zoom meetings like we're holding today. And I'll show you a picture in a moment. There's a team that's seated at the university. People Zoom in from all across the state, from health clinics, from every possible setting, and they're able to present their cases. There's a teaching function that happens, and so he was able to spread the knowledge that he had around a very specific kind of treatment that community providers with some additional training were able to do on their own. And so as he tells the story, he had like an 8-month waiting list for people to even get into his clinic. And once Project ECHO had really taken hold across the state, there's now a 2-week waiting limit, and it has stayed that way because people can stay in their home communities and get the treatment they need. So with the success that he found there, he realized that there were going to be multiple other applications. And so currently, we'll see some maps here in a moment, there are ECHO clinics happening across the country and increasingly around the world. And they're doing every possible sort of disease and condition you can think of. And there are some other Project ECHOs that are doing the kind of program that we're talking about here in terms of involving school personnel around autism, around a number of other things. So the idea is, similar, that there's a team at the U of R that has a lot of expertise and experience in working with eating disorders. And then there's a great population of students and families and personnel out in the communities where we hope that we can build some more capacity out in the school so that people can really serve the kids right in their home school and not have to be shuffling them off to treatment, et cetera. So this is a visual depiction then of what a Project ECHO can look like. Essentially, you're starting with a small group of experts who are reaching out to what we call the spokes, the hub to the spokes, and doing that teaching, that sharing of information. And once you have that many more people with a higher level of knowledge, they can serve that many more people in their community. So this is literally what it looks like. There's the team in the large picture there seated around a table. And depending on the condition, on the disease that one is treating, there could be all different kind of specialists at the table. Project ECHO for eating disorders, as it's currently configured, we do this project for providers in the community, medical and mental health providers, largely serving an adult population. And so for our group, we have medical providers, psychiatry, mental health providers, we have a nutritionist, we have the parent peer mentor that Mary mentioned, who is a parent herself of a daughter, adult daughter in recovery, and lots of years of experience, both as a parent and as a professional now, who works with parents. We have the care manager who is helping to connect people with care in the community and beyond. An adult peer mentor, similar function, able to talk with other people in recovery themselves. Young adult peer mentor. So there's a real comprehensive team with coming at this issue from all different kinds of perspectives. And so as cases are presented to this group, they have, can each speak from their own area and experience. And then what also happens is the group that you see pictured there and all the smaller pictures around the edge from clinics around the state in New Mexico in this case, are not only able to present cases and learn through the didactic portion of this, but also can begin to function as consultants for each other and share their experience as case, each of these folks may present a case and everybody can chime in terms of, they may have had a similar case, et cetera. So it really becomes not only, the experienced team sending out information, it really becomes a two-way process and in fact a circular process of people helping each other.
We also have Excellus Blue Cross Blue Shield Psychiatry on our panel. So I think it's great to have insurers as part. So that's a good thing. They're champions. So we really do have a very deep and broad team. So in terms of what a Project ECHO clinic actually looks like, we convene and do some basic introductions and announcements. There is a time for any questions or answers from previous cases or subjects that have come up. There are one or more case presentations with time to really present the case, to put your questions out there that you'd like to have answered, to get feedback from the team, from the other learners in the community, and then recommendations are made both as the case is presented, and then as a follow-up, there are written recommendations that can be sent out then. This is meant to be ongoing learning, so it's not necessarily a chime in once when you've got a case. The idea is to come as often as you can. And over time, then there's a schedule, a curriculum of didactic presentations. And for the school community, that could be some of the basics around signs and symptoms, management, but then could also get into some of the school topics around how do you work within a school team to support the community team and vice versa, working with families. All of those aspects can be portions of the didactic teaching as well. Case presentations is on there twice because we really like case presentations. This is just to give you an idea of how idea is spreading for these kinds of clinics. These are the major centers around the country now that are also beginning to become training centers and training more people, and the reach is really quite incredible at this point. And there are literally all around the world. I was just in New Mexico in October, and there were people there from Kenya, from Jamaica, from India. They're really these are taking off all over the place. And now that the Project ECHO model has been going for 14 years, I believe it is now, they've had time to do some really intensive studies or looking at the effectiveness of this model.
As they began to expand, they wanted to be able to demonstrate to folks that there was certainly benefit to be derived. And so there have been a number of studies that have shown the effectiveness of it. You want to do something more on that?
I was going to say, I don't know how many people in the audience are research minded, but we always like to include what the limitations are of the studies, so they're working now on doing more randomized control studies. That's what they're working on now. That's the next slide. The work that they have done, they've looked at these different domains. Like when you do CME courses, there's different levels that people try to evaluate in terms of the participant satisfaction, knowledge, competence, performance, and health. And Project ECHO has definitely shown changes in all those, and happily, it's shown some changes in provider competence. So the confidence people have with delivering treatments in some of these studies that they've done, and performance. So if you look over to the right-hand side, this is one of the studies, a longitudinal study, I think, of pain patients. And they were happy to discover that when they had done Project ECHO with the physicians out in the community, that the actual use of physical health services for this group of patients went up, but they were able to avoid additional mental health costs. They were able to avoid prescribing opioid medication, and they were able to just prescribe non-opioid medication. So that's all very good news. And then in the bottom box, actual outcomes, good outcomes for patient health included things like lowering acting out, and they didn't have to have as much restraint for elderly folks. People who had diabetes or HbA1c went down. So there's been some actual health outcomes. This is just so that the research-minded folks in the group know we're actually studying it. We're not just doing it, we're trying to follow it, okay?
So then in terms of responses from people who participated in these kind of clinics, the things that they found that were most motivating about this was there was an increase in terms of their knowledge. They were able to apply the knowledge currently and would be able to then with future patients as well. They saved on patient travel time, and there was increased collaboration with other specialists. And some of the other kinds of things that were motivating were being able to get continuing medical education credit. So far for our Project ECHO, we have social work credits available for the social workers in the room and online.
Free.
They help to prevent professional isolation, working especially with smaller, lower incidence populations and conditions. And they were able to share their knowledge with colleagues and try something new. In terms of barriers, like for all of us busy professionals, lack of time to take part in a clinic like this and get all the education and that experience can be difficult to arrange, and we understand that that certainly is true of school folks as well. Some of the other things where people were not able to get those medical credits, or there was no sort of financial incentive to participate, or they didn't have access to the video technology that we have going today. In fact, in case people are wondering, this can be as simple as sitting at a laptop. As long as it's got a camera and a microphone, you're good to go. You need a broadband connection, but it's a free, easy download in terms of the software. So for most people, and there are mobile versions, so you can do it on your phone, you can do it on your iPad. So for most people, there isn't really much technical barrier, and it's one of the reasons that Project ECHO chose the Zoom platform, is because it is easier to access, and you don't need even as much bandwidth compared to some of the other video conferencing programs. So I would assume that for most folks in this day and age, within your schools and within your office equipment, you should be able to get online and be able to access.
This is our Project ECHO.
This is our Project ECHO. So, we're again looking at this a little bit differently in terms of school personnel being the spokes instead of doctors' offices. And as Mary said earlier, you're seeing kids all day long, and so you certainly are running into kids who may be displaying or talking about some of the issues that she said. For eating disorders, as I described before, our team looks different than some much more medically focused conditions. And they really talk about this as being not telemedicine, where you might sit with a doctor on the other end of the camera, describe your symptoms, and the doctor gives you advice or medicine. But this is really about teleeducation and telementoring. both from the team of experts, as I said, as well as peer mentoring once people have more knowledge and experience. And the big idea here really is that we're moving the knowledge and not the students. So as Mary said before, the students can be staying in their home school with the folks they know, with their counselors they know, and get some additional care right on site and not necessarily have to go outside of school or for higher levels of treatment go further and further away from home. And it is mentoring that is based on evidence-based practice. And so you really are hearing about the top of the line evidence-based treatment that's available, and people can talk about how they're administering that treatment, et cetera. So I said before, in terms of the Project ECHO, the technology is really widely available. One of the things that we're still trying to nail down with folks, and perhaps both online and in the room here, help us think about, we currently do, for the providers in the community, we do twice a month for an hour at lunchtime. And so we're trying to figure out for school-based personnel, obviously we all have different schedules, but in general, trying to think of the time of day, perhaps the day of the week, that is going to be easier for people. We have talked to a number of groups already and begun to narrow it down. Our clinic days are Tuesdays to begin with, so we're planning to stick probably with a Tuesday. And we're thinking at this point, from what we've heard with folks earlier in the day, lunchtime is hard for lots of reasons. After school can fill up with meetings, et cetera. But perhaps early in the day, somewhere in the 8:30 to 10 o'clock range. In general, is that for the folks in the room, show of hands, is that in general a time that might be available? I see no hands. Okay, so that time doesn't work for this group. How about for the folks who are on camera? Can you give me an idea if that time might work for you? Let's see a few of you. Oh, there's some hands. Yay! Okay, we like those hands. So we will, continue to look at it. And what I'll ask each of you to do then is, we'll talk about, if for your group, is there a day that's better, for example. The way we do the case presentations is there's a set form that we'll use that will ask a series of questions just to be sure that as much information as you have available to you can be, part of the presentation, and asking about things that are going to be helpful for the team to learn in terms of making recommendations about follow-up with that student. And the cases are always de-identified completely. We are absolutely respectful of the privileged medical information involved, and so we try to keep, certainly no names are attached ever. We try to keep any identifying information out of the presentation, and if that, I'm sure that's part of the way you do business as well in school, but we're certainly available to help with that, and we look over all of the case documents that get sent before the presentation happens just to help you catch anything. And I think it's also important to talk about if you've ever, if you ever have a chance to see one of the medical presentations, it's like sitting in rounds. And so they give the, the vitals and the history of treatment and, all this medical stuff. And we understand that a presentation from a school-based person might look very different from that. And so you have the information you have. If it's a student you've known for a while, family you've known for a while, you may have a fair amount of information about their treatment history, whatever else. It may be someone who's brand new to your school or who just, let you know about an issue of concern. And so the questions really could be very varied. It could be, I've known this student, he's been through all of this already, the parents are saying this, what can we do next for treatment? Very sort of, clear case presentation. Another idea could be, we just heard this in the hallway and this is what the kids are saying, and we really want to talk as a group about how should we address this. It doesn't have to be a really specific case kind of question. We want to help people in the school environment think about the whole array of issues that come up in terms of what kids are reading, seeing, talking about, the behaviors you're seeing, et cetera. So it really could be a little question that you would just like some help with, or it could be a full-fledged case. But all of those would be absolutely fodder for bringing to the Project ECHO. After we're done with the presentation, as I say, we take notes during the presentation and then write those up and send them out to people afterwards, so you have a real tangible takeaway. For anyone who's getting medical credit, which is available, or social work credit, there is no cost for those. and we do the processing of the information and so on in the office. And we do ask, in terms of our own trying to figure out how effective these Project Echoes are being, our clinics are being, we do ask people to fill out a pre-survey, just what is your knowledge right now about eating disorders. And then after about 8 weeks or a certain number of sessions, we'll send out a follow-up survey for people who attend, just so we get an idea of, are we in fact increasing the knowledge and experience, et cetera, in the field in the ways that we hope we are. And those are, anonymous, et cetera, but it just helps us to figure out, are we on the right track? And at any point, we're certainly looking for feedback about ways the clinic could be more helpful to you, et cetera. So it's absolutely a give and take kind of process. So some of the goals, we certainly want to help build teams and improve team functioning around these issues, to enable school personnel to coordinate and integrate services with the care that's available in school and in the community. And certainly we want to decrease any feelings of isolation or anxiety, as Mary talked about before. If you are working with kids or families facing these issues, there can be a lot of anxiety that goes along with that, and you may feel like you're the only one holding that burden. We're trying to reduce healthcare disparities, especially around this condition, and want to try and have less variation in terms of the care that's received, so that people throughout our 30-county region could have some basic level of expectation of care. And that's why we want to help build this capacity throughout the community. And for the state who's paying for this whole project, certainly, ideally, there would also be a cost reduction in terms of services, both for psychiatric and medical acute services that sometimes patients with these conditions need. And we want to increase best practice prevention efforts, so we can prevent as many kids as possible from going in this direction, and also help build some skill and capacity around early identification of who these kids are and intervention when things are coming up. Be sure that there is access to quality care. We want to engage students and parents and guardians in this treatment process. They're critical to it being successful, and certainly are looking for positive health outcomes. So what you have here is the basic link. It ends with an N, which you can't quite see behind the picture. And for those in the room, you have the handout. For people joining us through Zoom, if you want to, my email is not there, but I'll give it to you. You can write down this link as you're sitting there, or if you'd rather email me, my name is there, Jim Whitmer. So my email is Jim_Whitmer at URMC, University of Rochester Medical Center, .rochester.edu. And I am the project coordinator and in the office 3 days a week anyway. And I'm happy to answer questions, send out materials, anything that people need in support.
I can do this part.
Okay.
So we're going to open up for questions in 2 minutes. I just wanted to share with you the work of the Western New York Comprehensive Care Center, so you guys know what you have free and available to you since you don't pay taxes. So the Western New York Center is basically charged with these 6 goals. Like I said, there's a center in Albany Medical Center and also at New York Presbyterian Hospital, and ours is based at Strong. It's a partnership of the School of Nursing at the U of R and Golisano Children's Hospital. We're the only state in the entire country that had the vision to legislatively mandate. There's a law that mandates these centers, which we're very proud of. So no one else has figured out how to do that yet. Now the challenging news is we have to go sing for our supper every year. So we all have to get in a car and go down and convince the governor and all the Senate that we need to legislate. This happens every year since 2005, right? So it's good for you to know that there's a set of people, professionals as well as lay people, who are responsible for the 30 counties, which I'll show you in a second, for comprehensive and integrated service. So we have to help people get access to services. We either provide it ourselves, and one of our affiliates, the Healing Connection, does it, or we find services for patients and families. We have a care manager who can help families and patients find their way, Jennifer Dry DeSanto, into care. We have an amazing parent peer mentor, Michelle Morales, who can help families, teach them what to do, go into their homes, help them with meal times, go to schools. Some of you may know Michelle and Jennifer. Do lunchtime supervision, teach the staff how to do lunchtime supervision. So you have all these people. You have a young adult peer mentor. We have life coaches, adult life coach and a young adult life coach who actually help adolescents and adults set goals to create a new life for themselves without illness. You can trap anybody in a room and make them stop or start eating, make them stop throwing up, make them stop exercising. But then what's really terrifying is once you've accomplished that, how do you have a life? How do you develop a sense of self? So the life coaches help them do this. So these are all free. So if you guys called us tomorrow and said, could you send a life coach down to BOCES or down to a school? We say, okay, tell us when, here's a person's name, they'll come and they'll sit with you. If you don't know how to talk to a parent, Michelle or Jen will come and sit with you. They'll be part of the conference with you. Well, all of that is available to you. And we do a lot of training. Project ECHO is part of number 5. Like, how do we do outreach and training? And then we do conduct research and outcome at the Healing Connection, at the School of Nursing on different topics to make sure that we're teaching you guys best practices. Our service area are the 30 counties in the light gray on the left. It's a lot. So we try to figure out how to spread the wealth, which is why Project ECHO is such a cool thing. You can involve 30 counties and invite them to be a part of this instead of me getting in the car, Taylor getting in the car, driving around hoping to reach everybody. So that's our service area. The core site, as I said, is a partnership between the U of R School of Nursing and Golisano Children's Hospital, where there's a child and adolescent eating disorder program, where Dr. Starr works. The provider regional sites are those we have champions in each of those areas. For Project ECHO, for example, where we've kind of targeted people or had presentations, and they kind of send out information to the people that they know. And then I've left on the slide here our numbers, how to contact each of us. And you've already seen Jim's information. These are all the different people who are involved in ECHO. And then I have a stop here. So we'll stop for a second. Dr. Starr, would you like to come up and show your face on the camera so people know what you look like? And you have actually presented in Project ECHO, so I don't know if you want to say some words about why it's so cool.
Hi, everyone. Yeah, it's been a great experience this year, reaching community providers and really increasing collaboration that always is best to help people in recovery. I think I've been sort of brainstorming different situations that I would imagine people in schools might want to ask us about, even based on conversations I've had with school personnel, whether it's coaches, a nurse, a guidance counselor, teachers who are concerned. So I'm excited for the conversation part of this, or the questions if you have any, but we've definitely had really effective conversations that I think really be helped by having a venue every few weeks to talk about students and or their families, or a whole classroom of people, of how we can help in terms of raising awareness, prevention, not even getting to the point where you think maybe someone needs treatment, but catching things earlier is what Mary is really focusing on. So I think it's just a really great illustration of teamwork and collaboration, improving the care of our community and in our state. So it's a pleasure to be part of. And we're not in this alone. That's like the whole thing. We know we come together and we can help our young people and their families and each other learn every week. So, yeah.
Great. Don't go too far away. So for people who are online, they could actually put something in the chat box, right, Jim?
That is correct. Yep. And let me get out of the presentation here.
And we, of course, want any questions or feedback that you guys have as well.
Okay, so it looks like a couple people have put their contact information into the chat, as I requested earlier. That's wonderful. Thank you for doing that. And similarly, if anybody in the online group has questions for us, go ahead and type those in, and I can read those out to the group.
And can I just, when I was new to this, I needed it explained to me like 20 times, even though my name was like on it. Right? So if anyone's brave enough, does anyone not feel like they can envision what this would look like? Like, are you brave enough to raise your hand, like not understand how it would look like for
For you guys.
for you guys.
Can I try to summarize what I
Yes.
understood?
Yeah, that would be
Yes.
good. Yeah,
Okay, and then you can help clarify.
yeah.
So what I'm getting is that you would like to spread your knowledge to us, and knowing that we will be kind of more the on-site people who will be able to use the skills.
Right.
And we
And
also
then it
would,
would take an ongoing monthly commitment.
well, we would, that would be
The more
ideal.
participation, the more you'll get out of it,
Right.
and the more your colleagues will get out of it. But yes,
Right.
so we can share. You can share your knowledge and
Right.
expertise
Right,
that you have
right, don't
every
forget that part.
day, working with the
Kids.
students, the families, the peers that you see every day, and your environment that you know so well with us. We can share our knowledge of the illness and working with young people and their families with you. So that's going back and forth. And then spreading that amongst yourselves. So say you participate 1 week, but aren't able to come to the one in 2 weeks, but maybe one of your colleagues can. And then you share the knowledge in between with each other and with the families and with the students. So sort of multiplying, spreading knowledge.
Right.
And yeah, so I think that is the gist of it. Can I just like throw an example? Yeah, go ahead.
And the other thing is that what I just heard toward the end, you were comparing, right?
Mhm.
Was if we wanted to do something with the family or the student, and we kind of felt like it needed to be done, but we were overwhelmed by the ability to do it, we can absolutely pick up the phone or email you guys. And you guys will be right there for us.
Mhm, mhm,
Right. Okay. That's-
mhm.
Excellent.
I'm
Yeah.
excited about that.
All of that and more would be, fantastic.
Yeah.
And then once you have that experience, then you'll even gain more skills
Right.
from that experience to maybe call us again for the next one, and then the one after that you do on
This
your
is
own.
all free.
It's all free. Isn't that amazing?
Indirectly, my next.
Right, you're right. That's totally
But
free.
your time, and so we do need to figure out the time that would work best for most people in your setting. And I know that's something that Jim had mentioned. But can I just, Mary, do you want to should I throw out an example
Yeah, no,
of how it would
yes,
work?
yes, yes, yes.
So just thinking about some conversations, for example, I've had collaborating with school personnel about patients that I'm taking care of. Before I was part of their care, often the person I'm talking to who's in the school is saying, 3 years ago, 5 years ago, I could have told you this, right?
Right.
I didn't know who to talk to because I didn't know maybe what it was called, or I knew what it was, but I didn't have the language, or I didn't know who to go to first, or I tried to have a conversation with parent X and didn't go well, or I tried to talk with a coach. So in those situations where you have that gut feeling, or you're seeing something, or as Jim said, you're hearing something amongst a group of, pre-adolescents or adolescents, and your spidey senses go off, that's when we want to talk. And
Right.
so even just a little blurb of, hi, I'm here today, my name is so-and-so, I work at this school, this is the age group that I work with, and when I was passing by in the library, I heard a bunch of kids talking about the latest fad diet. A few weeks later, I can tell that so-and-so is now skipping lunch, and I'm really concerned. What do you think? I mean, even something like that, and then you all as experts of spokes zooming in, because you work in the same type of environment, we'll be asking your colleague who presented questions about that because you work in that environment. And then that will give us an opportunity at the hub to then ask questions. And then that will give your colleagues an opportunity to give recommendations to you how you might handle it in your environment. And then the people at the hub can give our recommendations, and then we summarize all of that up in a document. And perhaps some of the recommendations are to have some of our team members come help you have conversations, or even a referral, or come do a presentation at your school on prevention. That would just be an example of how it would work.
It's like a super family meeting. I mean, think about all the very cool, smart adults in one room at one time. I mean, how many times in life can you really have that when you're struggling and you're obviously like, oh my God, what am I going to do? And you can come and you can learn from your colleagues, and then whatever we can offer. It really is a two-way street. We all learn something, you know what I mean? Because everyone's got talent and strengths, and we forget that in the face of the illness. We all get scared overwhelmed, distracted, we, shut down. And that's what it wants. It doesn't want us talking. Well, when the adults talk, we can usually figure out something.
And you all know the resources within your
Right,
environment.
right.
That when we're generating ideas or
Right.
recommendations, you say, oh, how about this resource, or how about this person, or how about,
Right.
this, whatever, you can help with the recommendations and then come up with some solutions and hopefully prevent further illness or get someone immediately to care if that's what it
necessary.
needs. Yeah.
Is there any chat questions?
There are no chat questions yet that I see. There were two things as I was listening that I want to just make sure people are aware of. We really are thinking of this in a very broad spectrum way. So I think we have a lot of sort of mental health kind of support people here today. But we really absolutely envision this for being anyone and everyone in the schools who's interested. Mary mentioned a couple times that people serving lunch are critical to this.
Oh, yeah.
They're seeing who's throwing stuff out. They're seeing what the kids are eating. So they have information that could be really valuable in terms of helping your students. Health teachers, classroom teachers, coaches, athletic trainers, all of those folks are seeing the kids who are spending every day in the gym, some of those kids compulsively exercising as a way to lose weight, et cetera. And so any and all of those people would be more than welcome to be involved. And so we would encourage, as you're talking to people about this, let them know they're more than welcome to register. And then a second point is, in terms of the learning process, we know people are busy, you can't always get there. Part of the way ECHO works is we also have a repository for information. It's called Box, similar to Dropbox. And so after each of the clinics, we put up the didactic presentation that's there. We have lists of resources. It can be used in all different kinds of ways. So if you're not able to attend a clinic, you still could go in at any point and access the information. And we've got quite a bit of it stored in there at this point. As specific to eating disorders, to services available in this area, all kinds of things.
Yeah, you just have to join. There was something else somebody said. Now I'm blocking. Yes, sir.
Have you used this process for kids that are coming out of intensive treatment and back into school?
That
So
it
they're already
could.
connected with you today, whether
Yes,
they went to
it can be used for that.
hospitalization or connection or something like
Question
that.
in case it's too far.
Oh,
And then coming back to school so that they're already connected, obviously, with treatment providers.
the question, I'm just repeating it for these guys. The question was, can this be used for kids who were in treatment or are coming back to school now? So what would be really exciting, this would be a great thing, if we could get all the school personnel on this kid on the ECHO with the provider. Wouldn't that be totally excellent? I mean, we have a provider ECHO that we don't have K through 12 on because we have college health, primary care, behavioral health, and it's generally not kids under 12 or 14. But in this situation, if you wanted to do that, it would be absolutely appropriate because it's that transition that's a killer. The transition back in can be really tough for the family and the kid.
Yeah, and we know, and I'm doing something on Friday, about collaboration with mental health and school and medical care and all of that. But often the recommendations the team is making for the child and family include school and include often like supervision or support at school. And so to get everyone on the same page as to what that needs to look like and how critical it is, versus, a lot of times it can be these non-school people making these recommendations and the school people saying,
Right, that's not going to do it.
Like,
right.
like, hello. So we definitely, there are gaps there. We need to improve communication. I think this would be a perfect opportunity. And even before we're in that situation, have a didactic
Right.
theoretically on if you have someone who is sick, who did go to treatment, who is out of school, how to reintegrate them, what would be helpful, what will support their education, what will support their medical care, their nutrition, their mental health, and what the team at school can do. And then what resources you do or don't have, the logistics of the day. And so coming up with a plan together would be best, yes. Like, duh, why didn't we think of this sooner, right?
Because we didn't have the school personnel in the room. I'm glad you asked that question because we're so focused. One of our agenda is that we want to get this sooner than later. But what you're asking is completely okay. Absolutely. Absolutely. You guys have other questions? Yes, ma'am.
They did a project similar to this and
Mhm.
we've included like a 1-year follow-up. And the case presentations are always really helpful to give the presentation helpful with the other people's case presentations.
Mhm.
It sounds like it's somewhat similar to that, having the providers, having experts on the phone, being able to sort of ask questions back and forth. I did have another question. I actually have a student who recently came to my attention who I'm sort of considering a lot of this for. So what would you recommend for someone who needs that assistance right away? 'Cause it seems like it would take time to kind of build the capacity and get all the training and everything. Would you recommend sort of linking them to one of these comprehensive care centers or one of the life coaches or one of the
We can talk with you after, and we can figure out where you want to start. Like, we can hook you up with Jen, our care manager. Like, if you hook up to any one of us, you've hooked up to all of us. But we could start with Jen or Michelle, because they deal a lot with the families and the kids and how to navigate what to do next. And then any one of us are helpful to be a part of a consultation.
By all means, if we're coming across a situation where we think someone needs more immediate intensive evaluation, the good thing is we're talking and then we'll
Right.
make that happen. We
Right.
can help set that
Right.
up. We're not insinuating that if they need it, we want to train everyone to do it. But
But we can train people in a lot of skills that, it's not rocket science. I mean, I'm not a cardiothoracic surgeon either, but I mean, there's some things that you can do as an adult that you just don't realize you can do in the school. Like, come on. So you got some nods back there.
I mean, I think the unknown is scary, and I did that, even though it was 10 or whatever years ago before I came to fellowship, when I didn't know what I know now, like I was scared because I didn't really
Right.
understand how to take care of patients who have eating disorders. And knowledge is power. And so, I mean, we know that you are all set up to learn this knowledge and then actually make a huge impact. So we're excited for this opportunity.
And
will this be launched?
January, that's the goal.
Not soon enough, right?
So the question was, when will we be launching? And we have a goal in mind of January, and we do have some tentative dates on a calendar. I will send out information. Unfortunately, the time we chose is not good for this particular group, but we can certainly send the times. And then if we really have, we've already had 54 people register for Project ECHO, which is actually too many people to have in one room. So if we really find that there's an enormous amount of interest, we may be able to come up with additional or other times, or at least flip the times so that people who want to be involved can be involved. So I think it's the second Tuesday in January is our soft target launch date.
And right now it's at 8:30 to 9:30. I think one of the challenges is that depending on what group of school personnel we're talking about, we get different answers. So like the counseling staff has a different answer than the nursing staff has a different answer from the coaches and the athletic trainer. It's been, we want everybody, but we also realize that it's hard, and adults get involved with kids at different times of the day depending on what their function is. Do you know what I mean? So the counselors are like, let us do this between 8:30 and 10:30 before lunch because we can. So anyway, it's monthly. It's once a month. So we were hoping that it wasn't too much of a burden. You know what I mean? If you could schedule it far enough in advance. But like Jim said, if we have so many people, maybe we can figure out what to do in terms of alternating times.
Is the Tuesday, right, like right now, Tuesday at 2 o'clock, okay? Who want to do hands? Who's okay with
I mean, it might be helpful, you have a group here that is clearly
Yeah.
interested, so if you want to let us know, do some
Tuesday,
internal
like the
polling
trend
and
right
let us
now,
know.
who's okay with that? Who's okay with that?
I'm sure it's not mental health.
Oh, no, the Tuesday date.
But there's only one day a month.
Scheduling is always a problem.
So it can be an opposite.
Oh,
Well,
okay, then we're
well-
fine. You're thinking that the third Tuesday.
We're thinking, well, for most of them are the
It's it's actually,
it's for
first and third is the current, one,
provide
right?
as a provider.
So many of them are the second Tuesday, and one or two of them are on the fourth in terms of room scheduling right now. But so and we can get those dates out, and so you would have plenty of time to plan around them if that's possible.
One of the challenges we also have is now we're with competing ECHO projects who are all vying for the same space and time. So we also kind of are at the mercy of the scheduler. So we're trying to take into account everybody's desires, and also we have to have a special room to do this in. That's the other challenge. But yeah, let us know if there's if this is not good, what the alternate would be. I don't know if 54 people are going to show up. They're registered, but like that would be a good problem to have. We'd love to have that problem. Anything else? Any other questions you have, either about the Project Echo or about the center? Okay.
For folks joining us by Zoom, I now have all of your email addresses. I will send out a copy of today's PowerPoint presentation so you have those slides and that information available. And that also includes all the contact information you should need and the registration information.
Is Lisa sending them out to everybody else, basically?
I think that in this group, yeah, they've all gotten a copy now, but
Okay.
we'll also make sure that Lisa has a electronic copy if that's helpful.
We appreciate you letting us come and use your time because we know how busy you all are. So if you have any other questions or concerns, and we'll nab this person right here before we go and ask her where she wants to start. But let us know, because now you have our slide with all of our numbers on it.
The last slide.
Oh,
You're kidding.
No, you're right.
Okay.
Yep.
So
We can resend
We
it.
do have an email. Do you want to email that to us?
Yeah, I have Lisa's email for this group, so I will send her a full copy of that presentation. There were a few pages left off of the copy. That's right.
I think Jen Dry DeSanto's number is probably important, 276-6102, right? She's our care manager.
They'll get them all
Okay.
when I send the full
Okay.
presentation. All right. Thank you very much.
Thank
for
you,
everybody's time and
everybody.
attention.
Thanks for coming.
Thank you for the folks who joined us online.
Thank you. Thank you. You're so cute. No, you were close. I thought that was good. That was good.